Are we ready to make a start? It's time, so we'll probably have people joining as we go. So just to say thanks for joining us all today. It's the second in our series of online educational events for palliative care with a primary care focus. Just to ask if you wouldn't mind all muting your microphones when you're not speaking, and to obviously let you know the meeting is being recorded. If you have any questions as we go along, please do type them in the chat. I'll be monitoring the chat, and we will have an opportunity for questions to be answered at the end. My name's Carolyn Berry. I'm a GP working in Your Health Partnership, and I'm also working with the palliative care team at Sandwell. So that's how I'm involved. As I hope you all know, today's topic is palliative care in heart failure, and we're hoping to share some insights into identification of people with heart failure and approaching the end of life, as well as looking at the MDT role and some practical advice. So our speakers today you've just met, we've got Dr Russell Davis, who's a cardiology consultant at SWBH. He's going to present first around management and prognostication in heart failure. We've then got Aimee Ridley, who's a heart failure CNS working at Sandwell Trust, who's going to share a case study, and Dr Anna Locke, who's a palliative care consultant, a core member of the Heart Failure MDT, who's going to, if there's time, have a chat about symptom control at the end, but obviously we want to allow opportunity for questions as well. So yeah, as I said, please share in the chat if you've got any questions, and I'm going to hand over to Dr Davis, if that's okay.
Yep. Oh, admit somebody. Sorry, you'll see things in the background. So we'll share screen. Oh, I don't know why that's appearing. Can anyone see the screen? Palliative care in heart failure, hopefully.
Yes.
Got it.
Yes.
Amy's got it, so I think we must have done. So thank you. I've been interested. I've been a consultant here for quite a long time, 22 years now, I think. And I've been interested in heart failure for most of my career, which is what I did my research in. I did do a palliative care course with one of Anna's predecessors, or two of her predecessors in the region who've now retired. But I did a course in palliative care, so-called Quasi, or consultant with another special interest, with Diana Webb and Alison Grove, who some of you may remember. Heart failure, as always, originally heart failure was a condition which was excluded from sort of the hospice movement and palliative care because of difficulties with prediction and organ failure. Patients often had as bad a time as cancer patients, but were not really looked after by palliative care teams. This situation has fortunately improved hugely in my time as a consultant, and I think the palliative care is an integral part of the heart failure MDT that was referred to earlier. And it is very important for patients approaching the end. And I think palliative elements of care can be considered even from an early, from the diagnostic point in heart failure to some extent, and, exploring what patients actually want rather than pushing them into having high-tech devices and defibrillators when really they didn't really realize the implications of what they were agreeing to, which I think has happened in the past, unfortunately. So you've probably seen these disease trajectory diagrams. They don't always make complete sense, but the idea is that we're in heart failure. You often get an improvement in functional level when you start treatments, and then have a variable phase of sort of plateau of maybe a mild limitation of activity, but they're doing all right. There is the possibility of dying at any point, which is unpredictable, often due to arrhythmias or new thrombotic events in patients with ischemia. And often you get this pattern about having a hospital admission where you suddenly become really ill again, and then you improve, but not quite up to the level it was before, and then further admissions, and then gradually declining. They tend to put arrows like this. Oh, if you have a heart transplant, you're cured. But there is a 10% mortality in the first year after a heart transplant, even though Britain's longest one has just celebrated 40 years, I think. But I think importantly, things like device therapy, so CRT for left bundle branch block cardiomyopathy, can transform things. So there are other possibilities other than having an LVAD or a heart transplant, which not without their own problems. What sort of things could we do when a patient has been stable with heart failure but are now deteriorating? So reaching one of these even a hospital admission, or maybe deteriorating in the community. I think a lot of patients were diagnosed quite a long time ago, when patients were given beta blockers and ACE inhibitors, but might not have had sacubitril valsartan, which is regarded as better treatment than an ACE inhibitor. The SGLT2 inhibitors have been rapidly adopted, but actually the evidence emerged. The trials were published during the pandemic, I think, in 2020. So patients who were diagnosed before that may not be on SGLT2 inhibitors, dapagliflozin and empagliflozin, and mineralocorticoid antagonists. Again, although they've been part of the guidelines for quite a long time, they were originally sort of reserved for the more severe cases from the RILES study, which was the first evidence. And patients may not be on these. So it's worth always considering, have we actually tried fully optimized medical treatment before we actually sort of go down a palliative route? It's worth getting a new ECG on patients. Patients might have had a new infarct, but it may be the damage is done if that's the case, but it's worth looking out for and see if there are possibly revascularization options if the patient's got angina. But has the patient gone into atrial fibrillation? This is important because of the associated stroke risk, but also they may be candidates for cardioversion or even AF ablation, which in very selected patients, the Castle AF study did show a significant improvement in outlook from AF ablation, if one can get one. It's rather a limited supply at the moment. And patients may go into a left bundle branch block with an associated deterioration of left ventricular contractility, and it may be that that's reversible with biventricular pacing, CRT. So it's always worth considering these things, and an ECG is a relatively easy thing to get. Check bloods. Has the renal function gone off, and the albumin level and so on? Has the patient developed anemia or iron deficiency? There are several studies that show a considerable improvement in quality of life with intravenous iron. Oral iron makes patients constipated, doesn't really work. So intravenous iron is actually the preparation, which is, there's two different ones, dirysomaltose and ferric carboxymaltose as well, have shown considerable benefits. Not much survival benefit, but a significant improvement in quality of life, even in non-anemic patients with proven iron deficiency. Always worth considering to try and improve patients' quality of life. If patients have angina, then it's worth considering revascularization options. There was a lot of enthusiasm for looking for viable myocardium and revascularization, but the revived BESIS-2 study, which came out a couple of years ago, suggested that actually revascularization with PCI didn't actually improve outcomes, or reduce arrhythmias either. So we're not tending in patients without angina to restudy the coronary arteries. And it's worth considering. There's all the organs are possible to be used for transplantation tend to be used at about 200 a year in the country. Is not going to be a solution for the majority, but for a select few, assist devices and heart transplantation do need to be thought of. So if a patient's deteriorating, it's worth considering all these things. This is from the West Midlands palliative care site, and I cut and pasted this, but it emphasises here that the 4 pillars: sacubitril valsartan, or if you can't tolerate that, a sort of conventional ACE or angiotensin receptor antagonist, mineralocorticoid antagonist, SGLT2 inhibitor, so DAPA and empagliflozin, and beta blockers. Ivabradine in a select few patients if in sinus rhythm and still tachycardic or hypotensive can be helpful. Some patients go into AF a bit more, and consider cardioversion if the patient's gone into AF, and possibly even ablation to prevent it happening again. The treatment options, as mentioned, people tend to talk about heart failure as though it's all systolic dysfunction, but there's an awful lot of patients with preserved ejection fraction out there, but who are, the ones who are really symptomatic and have recurrent admissions do just as badly as those with reduced ejection fraction, in some ways even worse, because we don't have really very good treatment options. Diuretic therapy to treat fluid retention is obviously sensible. The SGLT2 inhibitors have both now got nice approval after appeals from the makers of picloflosin to get put on there as well. But they've both got evidence that that they're actually of use in HFpEF, or heart failure with preserved ejection fraction, and really the first prognostically improving treatment we've got. So important to use those and consider it. Treatment of particular triggers and comorbidities, and the treatment of AF. AF can cause, AF is very, very common in HFpEF patients, but maybe, if they feel much better in sinus rhythm, then, cardioversion and rhythm management, amiodarone ablation is always worth considering. Um, when I did the palliative care course a few years ago, we also got a grant to do some education on palliative care and heart failure. This is about 2010 here, and we looked at various prediction scores. Most of them are for relatively stable patients based on analysis of clinical therapeutic trials, and are not really relevant to palliative care. The MAGIC score with big names you notice here, like John McMurray, Carl Svedberg, etc., big names in heart failure, got together and looked at these from observational studies. You'll notice that even here, even the highest risk group at a year, the mortality was only about 40%. So, but nevertheless, the score does predict quite well, and it's been validated. There's an online site which you've got here, MD Calc there, and you put in the details: NYHA score, are they a current smoker, do they have diabetes, COPD, are they on treatments, and so on, and you get a result out which might be useful in some cases. However, I think a simpler test, which we should hopefully have available, is natriuretic peptide testing. We've got NT-proBNP locally, and I think almost all centres are now doing NT rather than whole BNP. It's supposed to be restricted to patients making a diagnosis for the first time, but actually I'll show you some things, and I think it's a very useful tool to look at the prognosis in heart failure that's known, and the labs, as long as it's not abused, will generally be all right about doing them. It is about £25 a go, so they don't want thousands more samples sent to them, but it can be useful. So this is looking at ejection fraction and survival. These are patients referred to a heart transplant assessment unit. Roy Gardner in Scotland, some of you may know him as the just past chair of the British Society for Heart Failure. This was when he was a registrar, and the first time I came across him. But he looked at ejection fraction, VO2 max, difficult for patients to do on treadmills wired up to gas exchange machines and things. Heart failure survival score, a composite of other things, and this is BNP. And BNP trumps all the other measures in terms of prediction of prognosis. So so the N-terminal pro-BNP was extremely useful. They didn't actually publicize the units here, but here we are, the below the 70, more than the 75th percentile for BNP, progressively worse prognosis. If your BNP level was low when you referred to the heart transplant unit, you tended to live, and so probably didn't actually need to be in the unit. And I would test BNP before NT-proBNP before referring a patient for possible heart transplantation. There's more recent studies that have come out as well, looking at the actual you see the numbers of BNP. For a while we got more than 35,000, but I think they're actually starting in the Wolverhampton laboratory that does our analysis here. To give numbers above 35,000. They had a median level of 11,000 there, 11,700, and using that level, it's still the mortality was twice as high with those with an NT-proBNP more than the 11,500 than those below. So that's useful. And you can imagine that if you've got a BNP of 50,000, the curve will be right down here. And that's useful in predicting things. I think it's a powerful prognostic predictor when you first diagnose heart failure. If you halve your level or get it even better than that, that's associated with a much improved prognosis, and I think is a cue that you should go on trying to optimize treatment to try and improve the prognosis even further. The problem is, if the BNP levels rise despite good treatment, it's a strong predictor of mortality, and patients may do badly. You might, well, why don't we do it every month? But as I say, it's £25 a go, and the labs will start rejecting samples. But I think occasional use in prognosis prediction, and should we invoke palliative care, is, I think, very reasonable. What else could we use as well as the NT-proBNP? I think a lot of you are, enthusiasts about palliative care. That's why you're joining the meeting. But the SPICT tool is quite widely used. I originally thought that SPICT was an acronym, but unfortunately it isn't. We've got why might you be thinking about palliative care? Recurrent unplanned hospital admissions are a powerful prognostic marker, and that's one of the things to consider. Deteriorating performance level, particularly sort of staying in bed or in chair for more than half the day, increasing dependence on others, unplanned weight loss, going underweight, low muscle mass with cachexia, persistent symptoms despite optimization of medical treatment, and of course, if patients actually express a wish. We were discussing a patient today, the MDT, who's on dialysis, and do you want to go on with dialysis? Obviously, it'll lead fairly rapidly to demise, but that may be what patients want if life is not felt to be worth living anymore, and everything else has been excluded. And we've got in the heart and vascular system, heart failure, extensive untreatable coronary disease with breathless and chest pain. So these are our patients, really. This is from a national document which Jim Beattie, who I worked with the heart failure project educationally in sort of 2011, but he suggested using the SPIC tool plus other indicators. There are obviously a bit of overlap here, but frequent admissions or episode of decompensation despite optimization of treatment, particularly if you've got more than 3 episodes in 6 months, your outlook is particularly poor. Have you been listed for a heart transplant? And I think a palliative element of care, even for those who are actively being organs sought, they often won't get them, and they have palliative care needs here. Cachexia, if you've got a device, there are a lot of these patients who've got defibrillators intended to prolong life. But if they've got multiple shocks, they are unpleasant for patients, and they may be reaching the end despite that, and that's a poor prognostic sign. Resistant hypoalbuminemia, a sign of cachexia, really. Anemia and iron deficiency, which is addressable. Resistant hyponatremia is a poor prognostic sign. Comorbidity with a poor prognosis, such as cancer on top of the heart failure, which we see. So what should we consider when the end does appear to be approaching, using this combination of approaches, maybe with worsening symptoms, recurrent hospitalizations, rising BNP, etc. So it's important. What does the patient actually understand? We still get patients who think it's not a malignant prognosis, and you don't die of non-malignant disease. Well, obviously you do, but it's important that don't make assumptions that patients do understand this. A discussion about, would you want to have recurrent hospital admissions, or would you prefer to be kept at home, even if that meant dying at home? What is the attitude towards further hospitalizations? I think it's important to discuss the resuscitation status, and the supportive care plan is not a sort of, it's not tramlines, it's guidelines, but it may help you make sensible decisions for the future. Do you need a statin to reduce your 10-year vascular disease risk if you're 85 and have cognitive impairment, and you're reaching the end from heart failure? Really, is taking a statin appropriate? Probably not. It's worth looking at the defibrillator programming. I think leaving a pacemaker on, it's a bit ethically difficult. If a patient is pacemaker dependent and you switch the pacemaker off, then they die instantly at the end of the program, which I don't think is really on. But I think not having shocking functions from an ICD programmed is very sensible. And leaving it to the very end and calling out and seeing if you can find a physiologist to come to a patient's home in the night. You can put a magnet over the device which will inhibit it, but anticipating this in advance so that you can actually deactivate the defibrillator functions of a device in advance is usually very sensible, and we'd rather know sooner rather than later. As I mentioned, rationalization of medicines. Do they need anticoagulation still if they're reaching a terminal phase, and so on? Prioritization of symptom management over prognostic medications, which I just mentioned again. Does the patient still need bloods doing? You might say, oh, well, the sodium's a bit low, but is that really a priority if you're dying? Probably not. And there may be specific considerations with religious beliefs that you might want to get the family around. Is there a particular anniversary coming up that you really want to stay around for and be as well as you can, and so on? Always worth exploring all these things. So this is from the West Midlands Palliative Care site again, the section on the dying phase. So in general, it's sensible to continue with medications with symptomatic benefits and stop those aiming for long-term reductions in morbidity and mortality. In general terms, I think that diuretics are needed unless the patient is becoming dehydrated by not drinking enough. I think having bad symptoms of myocardial ischemia is not pleasant, so we would usually go on with anti-anginal medications, and you can use nitrate patches if patients aren't able to take tablets. Digoxin, well, if you stop it, they may get worse. So I think that it's reasonable to continue that. Things to consider: stopping lipid-lowering drugs, yes, definitely. Antihypertensives, doxazocin, that causes problems with continence in older ladies quite frequently, and meticulous blood pressure control is not going to be the key thing. Anticoagulants and antiplatelets may be stoppable. I think if you've had a recent coronary intervention, then the risk of stent thrombosis is still going to be high and may cause sudden death, unless it's really what the patient wants. Then you might want to consider it there. Slight issues with the this wasn't written by me originally. The spironolactone beta blockers, ACE inhibitors, and ARBs and things. I think that it may cause deterioration of symptoms stopping some of these medications, but if you think that the medications are actually causing side effects and we're entering a palliative care phase, then it's reasonable to think about them, but I wouldn't routinely stopping without some thought. Here we are, and there's defibrillator guidance here, which we've already discussed. As the heart is dying, obviously arrhythmias happen, and dying with a series of shocks, even if the patient's unconscious, it's very distressing to relatives and things. And if they're touching the patient and get a shock themselves, then it's not nice. So anticipation of these is very sensible. What Anna's talking about, symptom relief in a moment. This is again from the palliative care site. We've talked about breathlessness. Obviously, we may be able to optimize diuretic therapy, even at the expense of the renal function going off a bit if needed. There's I'm looking at a study about using a new preparation of furosemide subcutaneously, which is not alkaline and may have better bioabsorption, which we may be using in the future. If the patient's nauseated, diarrhea, drowsiness, confusion, they might have digoxin toxicity. Is it appropriate to continue? Digoxin levels can always be checked. looking at the blood pressure. Cough with ACE inhibitors, there are alternatives with ARBs nowadays. Cough may be due to congestion, of course, and pulmonary comorbidity. You might get malaise and lethargy from hypokalemia and other electrolyte, hypomagnesemia and so on. Beta blocker therapy may cause it. Despite what people thought years ago, beta blockers generally do improve symptoms. So I think that there's some slightly old thinking that still exists here. Bloating might be with gut wall edema and constipation. It may be sometimes bumetanide works better through an edematous gut and might work better than furosemide. I think it is important to think about IV iron, as mentioned, because we have seen some dramatic improvements in quality of life with intravenous iron. Tablets probably make patients feel worse rather than better, so it's not the same. General observations here. I think it's important to individualise care. These heart failure patients are not all the same, and we've been wrong with them. Sometimes we think somebody's dying, and 3 years later they're still coming to clinic and feeling a lot better. We have to be humble and sometimes admit that we've got things wrong. Decisions can be reversed, and I think it's important to listen to patients as to I'm actually feeling a lot better, Dr. Davis. We have to. No, you're on palliative care. We're not going to come off this. This is incorrect. And I think the bad name of the Liverpool care pathway was inevitably ended up with the patients dying and got a very bad name from it. Patients do have the right to change their mind. They might say, I would rather die at home. But actually, when it comes to it, they realise how dependent they're being to family, and the symptoms are dreadful. And they might decide that actually being in hospital would not be so bad after all. They do have a right to change their mind about things and the device programming. A good death may be quite labour intensive, but a bad death is also quite labour intensive to hospital staff and others. And we do need to be prepared to go the extra mile for patients. I think that even from diagnosis, an element of exploring patients' feelings and how active we should be with management, with devices and so on, that would be appropriate, even if not at the end of life, rather than putting a defibrillator in and then 6 months later saying, oh, we're going to deprogram this. This is not good use of £15,000 of NHS resources. That was some of my observations. Shall I hand over to Aimee to discuss a patient we've had recently?
That'd be great. Thanks, Aimee.
Thank you, Dr. Davis. So my case study is based on a 69-year-old female patient with a long-standing history of heart failure with reduced ejection fraction secondary to hypertensive disease. I thought it should be an interesting one to discuss because I actually have known this patient for a number of years. I used to nurse her in the community when I was a community heart failure nurse 3 or 4 years ago. And I saw her on a recent admission in December of last year, and the deterioration in her was really, really evident to me. She's got an extensive medical history, as you can see on the slide there. She's had recurrent hospital admissions over the last 12 months, predominantly for decompensated heart failure, where she's required high doses of intravenous diuretics that were gradually becoming less effective over time. If you look at her history, she has multiple signs of a very, very guarded prognosis. However, she was actually only recently commenced on the supportive care plan during the admission in December and referred to the palliative care team then. And I think in hindsight, this should have been done a lot sooner because her symptom burden has been very high and her quality of life is really, really poor. So as Dr. Davis mentioned in his presentation, we use the SPICT tool, and it helps us to identify patients with deteriorating health and who are potentially at risk of dying over the next 12 months. And if we look at the SPICT tool for this particular patient, she identifies with several of the general and the clinical indicators on there. So, for example, she's had a total of 7 unplanned admissions in the last 12 months. She's got persistent heart failure symptoms despite being on optimal treatment for her. And in fact, some of her prognostic medications have had to be stopped in recent months. She was previously on sacubitril valsartan, but this had to be stopped because her renal function was declining and she was suffering with hyperkalemia. She's also got multi-organ failure. She's got the heart failure with chronic kidney disease stage 4. And on top of that, she's also got severe obstructive sleep apnea and is now dependent on long-term oxygen. She's got deteriorating functional status due to a high symptom burden. She's now breathless on very, very minimal exertion. I would say she's NYHA class 3, borderline 4. She's dependent on her family members for her activities of daily living, and she's actually requiring carers now. And on top of all that, her NT-proBNP is 23,000. And as we know, that carries a significantly increased risk of mortality. So I've listed a few key points on this slide, as I feel like there's lessons to be learnt from this patient. I think she would have benefited from advanced care planning far sooner in her journey. We actually have regular advanced heart failure MDT meetings at SWBH, and it's attended by cardiologists. We have a renal consultant and our palliative care consultants. We discuss complex patients there and formulate plans of care collectively. I think this lady, she should have been discussed at our advanced palliative care MDT sooner so that a clear plan could have been put in place. When I saw her during the admission in December, it was clear just from having a short discussion with her that she was tired of being in and out of hospital. She wanted to be home with her family for Christmas. And clinically, as I mentioned, she was so breathless on such minimal exertion, and she was clearly in the end stage of her disease. I think some of the problems when patients bounce in and out of hospital is that they get seen by lots and lots of different clinicians on lots of different wards. And I think often we can get caught up with treating the immediate problem, and sometimes the bigger picture can be overlooked. I think there's a misconception that palliative care means that the patient is imminently dying, but in reality, it's about focusing on symptom relief while looking at the wider needs of the patient and her family and improving the overall quality of life. It absolutely does not mean that we're stopping treatment. This patient, she's now at home after a prolonged admission over Christmas and New Year period, but she's gone home with anticipatory medications. She had input from the Macmillan therapy team as an inpatient who really quickly put some equipment into place prior to her discharge, and they worked with her doing some fatigue and breathlessness management exercises, and she's also been referred to the Birmingham Community Palliative Care team. So I guess my take-home message from this case study would just be to please keep the SPICT tool in mind when you're looking after patients that have chronic life-limiting illnesses. If they're ticking those general and clinical indicators, and you're identifying poor prognostic markers, and you think that they may be at risk of dying within the next 12 months, then please consider advanced care planning. I think Anna's going to do a section now, are you?
Thank you, Aimee. Yeah, Anna is about to talk. I just wanted to quickly comment on that case study, which was really helpful, just from I guess a primary care perspective, because obviously you mentioned, should have been discussed in the heart failure MDT sooner from a secondary care perspective. But just to flag that as GPs or other healthcare practitioners in primary care, that obviously we could have picked her up as well, couldn't we? So
Absolutely.
Things like seeing a discharge letter over and over again with the same issue should flag it for us. Within YHP, we've just started a complex MDT each month where we invite members of the community heart failure team to that meeting. So thinking about ways that you can engage community teams to ask questions and have these conversations if you're not sure as well. I guess are things just to think about in trying to do better for our patients and get advanced care planning sorted, like you say.
Thank you.
But I just mentioned that this one was actually one I suggested. The personal touch, you'd actually looked after her before. I hadn't realised I suggested her. One of the things about this one was that when I went to speak to her, and her son, when I was consultant of the week, it was between Christmas and New Year, and I mentioned the fact that I thought she was unfortunately dying and we were running out of options. They knew this, that nobody had actually said it to them, but they knew it and were actually very pleased that somebody finally actually said it. But why had nobody said it before? Unfortunately, as you mentioned, she was seen by different cardiologists, and often maybe if she was on the Sandwell side by one of the interventionists who, are always looking for active treatments rather than the palliative approach sometimes. And in fact, they knew about it and were extremely pleased that somebody had finally said what was fairly obvious to them.
Yeah, I think Russell, that's what happens unfortunately in hospital a lot, doesn't it? And I'm speaking as a palliative care doctor who goes between acute and community settings. I think sometimes our primary care colleagues have one over on us on that, in the fact that I know the sort of model of a GP who sees the same people all the time, same patients all the time, is somewhat gone. But I think primary care probably have more chance of continuity than a sort of acute medical take. And sometimes within the hospital, it's the clinical nurse specialists who hold that continuity, who will often go to cardiac failure doctors and say, actually, I saw them last time, this is how things have changed. But I think in primary care, it'll be the district nurses, it'll be receptionists, it'll be people who, notice that someone used to come up for their prescriptions or their appointments and now isn't coming. So I think it's a whole team approach, really. And yeah, 7 admissions, it must have been pretty ghastly for her, mustn't it? Really. And I think we're kind of the conversation about sort of stopping medicines at sort of end of life is one that we're increasingly finding people are able to get their head around. Okay, when someone's actually dying now, we need to make some decisions. But I think the sort of the magic is going to be pulling back earlier and looking at people holistically earlier on and saying what's going to help, what isn't really helping, and actually what symptoms might people have that we can really help with their quality of life. And I've just got a few very brief slides, because I think we could have a whole afternoon on symptom control in heart failure, because unfortunately the evidence is that dying of heart failure is just as symptomatic as dying of lung cancer or chronic obstructive airways disease. And what I'm going to encourage you to do, people who are on the call, is to actually open this guideline, which is what Russell's been referencing through his talk. And I have a vested interest in that. I edit it, and it's been written by consultants and pharmacists and palliative care specialists from all over the West Midlands for many years now, and it's really helpful if Russell says, oh, this is a bit out of date, because we can change it. But there's a paper version and an electronic version, and the electronic version is free, and we do have a whole chapter on heart failure, but it does overlap with other aspects, because often many of our patients with advanced cardiac disease, just like Aimee illustrated, also have maybe chronic renal impairment, so we'll need some special adjustments. And equally, sometimes we have patients with liver failure who've also got heart failure, or a cancer that they've been living with for a number of years and develop either treatment-related heart failure or just have both, because especially for those of us who work in Sandwell, West Birmingham, we have a lot of people with multiple comorbidities dying younger than in other areas. So these guidelines should cover most things a generalist needs to know. There is a specialist section as well, which is where our defibrillator information is. So let's see if the slide will work. Has that worked? Interesting. No, that's actually clicked me straight onto the website. There we go. I will stop that. Hang on. That's the actual live website. So I'm just going to share again, because hopefully it'll work better. So the main, I'm going to have to just use the website. So the main symptoms for people with heart failure are things that we don't necessarily ask about, and often the things we don't ask about are the ones that we find hard to manage. So breathlessness is something that clinicians often reach for oxygen. There's not great evidence that if our patients aren't hypoxic, and many people with heart failure aren't hypoxic, oxygen doesn't help and often tethers people to their bed or wherever the oxygen is and makes them more at risk of falls. And the core management of breathlessness in advanced heart failure is non-pharmacological, just like Aimee was referencing. So relaxation, breathlessness management techniques, using a fan. There's very good evidence that fan therapy, so a simple hand fan, also in COPD, is as effective, if not more effective than oxygen. People can put it around their neck, just a Marks and Spencer sell them, loads of people do now, the rechargeable fans. But the feeling of air on your face makes people feel less breathless. And actually, if we're trying to manage how people feel, that's important. On this website, there's actually, in the specialist section, there's a really brilliant guide to manage chronic breathlessness that talks you through all the different options. It's got links to videos for patients, guided visualization and relaxation, some links to where you can refer patients for breathlessness management in different places. At the sort of end stage, when you've been through those other things, there is evidence that slow release opioid can help in breathlessness, but it shouldn't be the first tool in our toolbox. Opioids have side effects, constipation, nausea, drowsiness. They do accumulate in renal impairment unless you choose wisely. So they're not without risk for our patients, but it's something we should think about. And by the time someone gets a specialist palliative care team, often we are doing that, but we will do it alongside complementary therapies and other practice. So fatigue is another often overlooked symptom that patients with advanced heart failure can find very distressing. It's something we don't have a magic treatment for. Sometimes just acknowledging it and saying it's common. I think if I ever manage to find a treatment for fatigue, I can retire a very rich lady. But just like Russell was talking about, excluding anemia or hypokalemia, and then thinking about actually how do they manage their day-to-day lives? Are there things that can be done to help them manage their the energy they do have, but also using some gentle exercises to try and build some muscle, and looking at nutrition as well. Pain is also very common in heart failure. It's harder to pin down often than say cancer-related pain, because it's not necessarily one site. So you might have somebody who feels general pain, and often it's not particularly opioid sensitive. So again, you might be looking at non-pharmacological management, or a lot of our patients with heart failure often have chronic pain as well. So it might be we don't go down exactly the same route as we would for someone who'd say got a cancer in their lung pressing on nerves. We'd have to look at different routes, but again, thinking simple, what we can do, acknowledging, recognizing and managing. Nausea and vomiting. A lot of people with heart failure do feel quite nauseous, and I would say, again, trying to think about what might be causing the nausea. We do tend to, and I'd be interested to see what Russell thinks, we tend to avoid cyclizine because of its antimuscarinic effect. And I think once someone's entering their last weeks and months of life, people tend to be less worried about, I don't see this with, it's not about wanting people to die, but the balance of risk and harm changes. And if someone's nausea is not managed by anything other than cyclizine, then we might make that choice, but we might be more likely to think of something like domperidone as first line. Constipation, common, everyone gets it, it's totally overwhelming and annoying, frustrating, and the key to that is really very straightforward, symptomatic management of constipation and looking for any causes that we might be missing. Again, every time we start a laxative, we have to start opioids. It's nice guidance. Dry mouth, again, very common. Another symptom we miss. I always try and look in people's mouths, and I think in the days of video consultation, this is something that's quite easy to miss. And sometimes you can have candida that looks red rather than white, especially when it's early. And candida going down the esophagus can sometimes be contributing towards nausea. Skin problems, dryness, edema. Making sure we have to make sure that we don't put patches, so opioid patches on edematous skin or syringe drivers in edematous skin. So this is a very long list, and you imagine what it's like living with your advanced heart failure with all of these things. But again, depression often missed in palliative people in the palliative phase of their lives, and we do have to balance up whether starting an antidepressant is actually, if someone's likely to have a long enough prognosis to benefit from that. And sometimes we mistake sadness for depression, and it can be hard to untangle sometimes the sort of physiological impact of someone's advanced heart failure from actually just their mood. So if someone's not eating because of their heart failure is advanced and they're not hungry, so they're developing the anorexia or cachexia, sometimes people think that's because they're depressed, and sometimes the conversation actually needs to be about what they can manage eating wise, rather than actually that they might frankly be depressed. So those are the most common symptoms, but they're not the only symptoms. And I think at the top here we've got a link to the an IPOS questionnaire, which we're increasingly using in Sandwell, and I think quite a lot of areas using it now to try and systematically what's the right word? Systematically manage people's symptoms and not miss anything, because it's very easy just to go and ask for the things that you're interested in and the things that you think you can help manage. So that is a whiz through symptom control. I'm conscious that we've not covered everything. It's probably time to bring Aimee and Russell back in, if that's okay. I can see the chat's very quiet. Maybe people have said everything you want to know. I think Carolyn's going to ask some questions from her perspective as primary care clinician, if that's okay. Please, if you've actually got questions and you want to ask them yourself rather than putting them in the chat, please just put your hand up and we'll bring you in.
Thank you. Have you muted yet? Because we're in the same room, so we'll echo if we don't. Thank you all for your really engaging and really practical presentations. They're really useful, and some quite a lot of new stuff for me. I just wanted to reference. I think the SPICT has been mentioned a few times in terms of prognostication. Obviously, within general practice, we also sometimes use the GSF prognostic identification guidance. Very similar, to be honest. So it doesn't really matter what you use. It's just that you do think and ask these questions and consider the appropriateness of whether palliative care and advanced care planning needs to happen. I thought, Dr. Davis, the BMP element was very interesting. I've not heard that before. Do you have any suggestions about when we ought to be checking that? Obviously, like you mentioned, I feel like if we all start doing it, the labs will bounce it. And I don't know if there's any progress to making this part of any guidance or anything like that, or whether this is just your observations.
It took years and years for getting NT-proBNP. We started working. I mean, I did some work with it and doing research in the 90s, but we started doing pilots of BNP testing. It was whole BNP originally in sort of 2002, 2003 when I first started, and then we then only actually got it in any form of routine practice around about 2010, and it was in general practice first, but and GPs could use it as a rule-out test for heart failure because that's what NICE suggested. And it took ages. We've only got it in secondary care in widespread use for the last sort of 2 or 3 years. I think because Russell's Hall and Wolverhampton were using it, then during the pandemic they were just a bit soft with us and started letting us use it, and we eventually managed to sort out the money. But even then, persuading the powers that be, oh, here's a test, and we need sort of 30,000 a year to fund this, and the initial response is always no in the current financial situation. So we don't want to have lots of tests, but I think that I'm sure that we've seen some GPs sort of randomly checking BNP levels, and then it's high, and referring back to clinic. Well, we know this patient has an EF of 30 and is actually stable symptomatically. So why did you do the test? So I think it does need to be done in sensible terms. But if you've got a patient and they are worsening, and you've got a very high NT-proBNP, then it is one of the cues to think about palliative care. And should we continue with the defibrillator being functioned? I think if used sparingly, it can be very useful. But as I say, if we do too many, it's likely just to be turned out. Anna, you are muted,
Yeah,
I think.
Yeah, it's okay. I just, Carolyn and I have to not be on at the same time. So I recently requested a pro-BNP, or we did, for a patient who'd been stable for a number of years, who I was actually a bit hesitant about whether it was appropriate for her to carry on seeing our service. And if you remember, it came back very low. And actually, it really helped us with discharging her and kind of recognizing that her disease was now very stable, and actually keeping her under a specialist palliative care service wasn't appropriate. She was really pleased. It was really nice to be able to tell her that actually, she was unlikely to die of her heart disease in the near future, and that she could focus on living her life, which is, I think, what she needed to do. So doing it for a very specific reason did really help us.
There's a question in the chat which says, in the context of palliative care for heart failure patients, I'm interested in understanding the multidisciplinary approaches employed in addressing sudden deaths. Could you elaborate on the strategies or interventions implemented to manage and navigate such situations effectively? And how do these approaches align with or differ from general palliative care practices for patients with heart failure?
So I think that's really asking about maybe people who are likely to have cardiac defibrillators in. Is that the sort of people who you're thinking?
I mean, in general terms, yeah. Well, we'll let the questioner ask a question. I think that patients with heart failure can have a sudden arrhythmogenic death at any time. It does look as though the risk of this is reduced by the optimized treatment, the 4 pillars that we've gone over in great detail, but it's lower with sacubitril valsartan than it is with a conventional ACE inhibitor, and that was fairly well demonstrated and things. But patients, particularly if you've got a large ischemic scar with a lot of gadolinium enhancement on an MRI scan and things, and an ejection fraction of less than 35%, you are at considerably increased risk of sudden death, which is why the defibrillator has been proven to prolong life in this situation. One can argue that, the trials were done before current optimized treatment, and people are we've been wondering about participating in another trial to see if the guidelines are still appropriate. But patients are getting defibrillators, and then there's the issue about, you've got this device which costs an awful lot of money to the NHS, and shouldn't we leave it on? And I think traditionally some of the implanters of oh no, I put my device in, no, you can't possibly switch it off, has been an end of conversation. I implant these devices, and I think it actually, the possibility of what happens at the end of life actually ought to be part of the consent process before you implant the device. But is it? I think it frequently isn't. I think it's fair to say. I don't know if
I think people forget as well, don't they? I mean, I think, the whole overwhelmingness. I mean, I think that's a lot of the issue of conversations that happen in a hospital setting, where people do forget what they've been told. And I think that kind of ongoing kind of day to day, so primary care's role in that is, it might be kind of acknowledging that we're hoping this is going to help, but at some point, if someone's getting more unwell, actually this might, especially if someone's having an awful lot of shocks, because they can be really painful, the kind of, for some patients, actually they say it's really, I don't want it anymore, switch it off, and for other people they're desperate for it to carry on. But then how you die as a defibrillator just keeps going off, is also not a nice thing. But I think that, just going back to your question about for sudden deaths, I think we need to move to a situation where, for everybody, we're asking people about what their priorities are. If you're living with heart failure, understanding what's important to somebody, so that if they do suddenly get more unwell, because I think a lot people don't actually just suddenly die. I mean, so some of these patients do have sudden events, but actually what a lot of people mean by sudden is they were okay, and then within a couple of weeks they died, and things change quite quickly, and they maybe end up in hospital, and as a GP you might only see that, oh, they've died in hospital, and that felt very sudden. But often most deaths at 60 to 80%, depending on which stats you look at, are quite predictable. And it's trying to sort of make it normal to talk about the future with everybody, especially if you've got something like cardiovascular disease, rather than making. I gave one of the cardiologists a bit of a, I can't remember who it was, 2 weeks ago. They said, oh, we're going to make them palliative, and I was like, I think they're doing quite a good job of that themselves. Like, it's not, as doctors, it's not in our gift to sort of make someone palliative, but actually the people do get more unwell, however much we try.
Can I just ask one more question on expanding a bit more, if you would, on the rationalising of medications? I know you referenced the palliative care slides and said that some of it maybe you weren't sure on. I think it's easy at the very end of life, isn't it? You know, when days are last days to cut medications, because then it's all about often the patient struggling even to swallow. But have you got any more to add about timing of things like how, you know, at what point are statins useful or not useful, and at what point are things like you mentioned, the beta blockers and the ARBs and things?
The statins is a fascinating one. There's a lot of obsession with lipids, but actually there are 2 randomized trials of statins in heart failure, and do you know what the results are? They don't help. That's it. One was all ischemic and one was half ischemic and half dilated cardiomyopathy. And statins made 0 difference. And people thought the trials were unethical to do because everyone knew what the answer was going to be. But no, they didn't. They were neutral. But then, you know, we've improved the prognosis since then with heart failure so much. One could argue that that you know, maybe reducing ischemic events is worthwhile. So in general terms, these patients are do tend to be treated if they've had a previous infarct, and you know, it's part of your quaff that they should be get treated and all that sort of thing. But beta blockers and things, in general terms, things that actually reduce hospitalization rates probably improve symptoms, and all of the 4 pillars do reduce hospitalization rates, so they probably do improve symptoms, unless you're in the really sort of cold and dry phase with a very low blood pressure, when you know you might want to try and withdraw treatments. But in general terms, things that have been proven to reduce hospitalizations probably actually improve symptoms as well, and stopping them might cause a recurrence of symptoms.
Thank you. We're coming to the end of the time. Has anyone got any further questions? I mean, if you want to just raise your hand as well, we can take verbal questions just before we finish this webinar.
Could I just ask a little bit more about getting some more information around the generalised pain and some of the causes that could be?
Is that Steph? Hello.
It is.
In my team, we might have to do something about this, mightn't we, in our team? So I think a lot of patients, with what I see, is when with heart failure, it's related to lack of mobility, but they will also, if they've got chronic renal failure, they might have neuropathy related to that, their diabetes often, which has caused that. So it's more kind of chronic pain. I don't know, Russell. I mean, I've got some very specific patients in my head who've got very specific heart failure causes of pain, but I think in general, it's more aches and pains related to the heart disease, and heaviness of legs and things, which are not so drug amenable. Aimee?
I mean, they can get. Sorry, I've got the. We only got one microphone. We're chatting. You can get sort of hepatic congestion, and you know, stretching the liver capsule, and get pain there. And of course, the patients are immobile and get constipated, and you get abdo pain due to that. But of course, a lot of them have got a lot of other issues that they're, you know, in their 80s, and they've been turned down for orthopedic surgery because they've got heart failure and heart disease, and so they've got got pain from other causes of arthritis, and then we tell them they can't have NSAIDs because they're bad for heart failure and so on, and all this sort of snowballs, I think, sometimes.
And angina, of course, sometimes related to their heart disease, but if they've got ischemic disease. But yeah, it's a case of working through everything and sometimes acknowledging we can't make it all go away. But yeah, sorry, Steph, not to be very specific.
No, thank you.
Okay, thank you everyone for coming. It's been really great, and thank you to our speakers for such great, interesting presentations. I think you all probably registered for this event through Eventbrite. So hopefully you've seen that there are future events coming up, which Anna's just shared on the screen. We're holding them every couple of months, trying to go through over the next few months the main sort of palliative diagnosis and symptom control and things like that